So I'm really excited to move us on and introduce Dr. Silvia Vilarinho, who's going to bring us who's going to bring us a new topic and address the adult population who experiences PFIC. So thank you very much for joining us.
Hi, everyone, and can you hear me? Hi, everyone. Yes, and it's a pleasure to be here. Thanks for the opportunity. As you will see, I'm an adult doctor that with time became, I guess when you are a doctor, take care of patients. It doesn't really matter how old they are. You just care about them and care about why they get sick. And if we can understand why they get sick, maybe we can treat them better. It really summarizes kind of my journey in medicine. I think I had one first slide without the quotation marks, but yesterday after that talk, which I think it needs to be continued, I put the quotations mark because I didn't come up with a better idea, but we all know why we are here and why we are talking. All right, so just to kind of, we all think about these. I think why we care, why we have a diagnosis, and we heard quite a bit from the parents, and I myself run a non-diagnosed liver disease clinic at Yale, so many times I encounter patients looking for an answer for decades. It's to have a diagnosis so then we can think about what would be the best treatment, because as a liver doctor, what we don't want is that whatever it's insulting the liver continues to be there and leads to chronic inflammation and chronic scarring. And I heard from one of the moms today the very clear distinction of when you get cirrhosis, you don't want that to get decompensated, because at that time, as we also heard from the previous talk, many treatments that could have worked early on will not be applied at that time. And unfortunately, at that time, the only solution that we have in 2024 is a liver transplantation, which we heard some excellent stories, but we also have other cases where the transplant improved, but it really comes with other complications. So what I'm trying to say is that we really want to make the right genetic diagnosis the earliest we can, and then, as you will hear from the research workshops, understand what's going on so we can partner with industry and academia to develop new therapies. So also another concept I would like to bring to this audience is why now we are recognizing these diseases in adults, and that has to do a lot of the explosion of genomics. So around 20 years ago, in 2003, it's when, with a massive injection of money from Bill Clinton, we completed the sequence of the human genome. Only 20 years ago, we found out that the human genome encodes for approximately 20,000 protein coding. We had no idea what this number was, let's say 30 years ago. Then after finding out, and a lot of us working really hard across the world, what you can see is that, I just did something, okay. I will explain, I cannot point for some reason. So the mustard color line really tells you the sequencing cost. And as you can tell, in the last 20 years, it's going really down. And that really shows that with the gray line, the number of genes that we are discovering and this is just liver disease, goes from around 150 that we knew that if you get the mutation, you get disease in 2010, and now in 2024, we know that there is around 300 genes, that when we get that is mutated, it causes liver disease. And I put this line just to avoid the numbers again of the nomenclature of PFIC, but what I can tell you is until 2014, there was just the PFIC 1, 2, and 3, that's why we use that name. And then after this development of advanced genomics, and there are a lot of us being able to look at these questions, many other genes have been come up that have been classified in this realm. So what I want to share with you, why I'm getting more and more interested in this topic, is because at Yale, we were seeing patients in the adult clinics that we ran all the tests that we could think of, and we couldn't figure out why they had liver disease. And so we came up with this idea of just sequencing these individuals. So we take DNA from a buccal swab, a saliva, or blood. We isolate the coding part of that DNA. And this is important. It can get nuanced, but I would like to bring this concept in a few slides. So most of these studies were looking for the coding part of our DNA that only represents 1% of the genomic DNA. But we believe that it really harbors most of the mutations that cause disease. And then we analyzed it, and what we found was that 5 out of these 19 patients that were severely worked up and we couldn't figure out the cause, they actually had a monogenetic cause. And most of the patients had cholestasis that we couldn't figure out, or actually they had accumulation of fat in the liver, but not metabolic syndrome. And of course, for the purpose of this talk, I'll focus on the ones that had cholestasis. And so I know, because I was connected with some patients and families that had diagnoses in adulthood, I want to just share a little bit of one of the patients. She was a 32-year-old that actually was transferred to our hospital, pregnant on the 2nd trimester, and had a variceal bleed. So that's why we got involved in the case. And when we started seeing, she already had, of course, decompensated cirrhosis. We just managed the best we could, and she actually delivered the 2nd child well. But then afterwards, we wanted to understand why she had liver disease. And on the right side, which says patient 2, that's her biopsy. So she, as you can tell, there is some nodules. So she already has cirrhosis of the liver. And she had MDR3 deficiency. So she had 2 copies on ABCB4 gene, and she was just diagnosed at 32. And when you question her, she said that a few times in her life she had blood work and the liver test was mildly abnormal, but she never followed up, or she was never told that that was important. She never had other symptoms or hospitalizations. The other case we made a diagnosis at that time was a 29-year-old that actually had a transplant at the age of 8, but at that time, nobody, it said for reasons that remain unexplained. And now he came at 29 because unfortunately he was not taking his immunosuppression drugs for transplant, so he was having rejection of the organ. And we looked back, and actually his transplant was done in our institution. So these actually on the patient 3, again, you see these nodules, this is cirrhosis of the liver. And we found out that he had the MDR3 deficiency. So this got the interest of also some young students, which is great because I think we need the next generation also to know that this is a disease that can present early in life, but also later in life. And one of them moved to another institution in the US, in Boston area. So we decided to do exactly the same approach, but now with more patients. And again, as you can see, out of 52 individuals that we couldn't understand why they had liver disease, 17 had a monogenetic disease. They all tended to be younger than 40 years of age, but there were individuals that were older that we made the diagnosis. And again, the 2 same classifications of patients that present in adulthood with the unexplained form, and one of them, for the interest of this audience, is cholestasis. So when we look at those 8 patients out of 17 patients with cholestasis, again, 5 of them had what I will call ABCB4 related disease. The first 2 already had cirrhosis, and the last 3, I will go into a little bit more depth into that because I got some feedback that was the interest for some of the families of the presentations of the heterozygous mutations. We had a patient with BSEP deficiency and another one with Alagille, and we are diagnosing actually more Alagille patients in adulthood that didn't really come to medical attention early on. So this is a really great review that I really enjoy, done by all of them are pediatric hepatologists. One of them, Sol Carpen, is here in the audience. And it really gives you a sense of how many genes can cause bile acid disease and cholestasis. And for now, we know 58 genes, and I suspect that we will discover more in years to come. And you will see your favorite gene in this list. Okay, so just a little bit about ABCB4 related disease in adults, because it was a little bit of my interactions with patients in preparation with these, and it has a lot of nuance, so I will leave time for discussion. The way I think we'll start with simple things and then go into a little bit where the nuance is. I think we can think about patients with one mutation. So you can say monoallelic, so you inherit one copy of any gene of your interest from your mom and one copy from your dad. If you only have in blue, I'm putting, if you only get one copy that is not perfect, for the lack of better word, from one of your parents, but then you have a very good copy from your other parent. And in that case, it has been described that you can have intercholestasis of pregnancy, you can have gallbladder disease, that I will put that as a LPAC, and you can have drug-induced liver injury. What we see, I see quite a bit in clinic of patients send it to me is late teenagehood when they start taking a contraceptive, so high in estrogens, and develop jaundice or cholestasis or sometimes even itching, and was related to a drug. You can also have been reports on certain antibiotics. Then in red, you see the classical form where you inherit two copies that are not great, one from mom, one from dad, and you have biallelic disease, the classical disease that was described, I believe in the 90s with PFIC3, or you can call it MDR3 deficiency, that we think it's of early onset and more severe. What we are facing now is that we don't know this spectrum between patients that presented with intrahepatic cholestasis of pregnancy. If I was giving this talk 10 years ago, I might say that there was just the second hit of high estrogens that the patient developed disease, and then as they deliver the baby and the hormonal levels get more baseline, the disease is solved. What we see now is, biochemistry speaking, the labs look better in some patients and normalize, but there are others that don't. And what happens to those individuals? Will they progress to something that is very severe with cirrhosis and portal hypertension and even possible need for transplantation? I don't think nobody really knows. Same thing with gallbladder disease. In some patients, it looks like that is the only consequence of this genetic defect, if you only have one copy that is not great. But we see that other patients actually continue with abnormal liver tests, and we need to monitor and really follow them to really, in hopefully 10 years, I'll tell you how do they do and if there is a relation between genotype and phenotype. So all these questions are a little bit still open in the air. I also put two other papers, there are a few more. One is very recent from a Chinese group with a large data set looking at these questions that we are all interested. The other one was led by Richard Thompson, who I believe is in the audience, where they are also very interested in looking at these genes in adulthood. And here is also from Richard Thompson's paper, some idea of hypothesis of how you go from having the disease severe in red, where it's related to very little function of ABCB4 and MDR3, versus having a little bit of dysfunction, but maybe not causing disease. And I think I will stop here for now, and then we can have a good discussion on that. And I'll bring this to the discussion. Could it be because actually there are mutations on the non-coding part that we are not looking for them, and therefore we are not identifying? Could it be that there are other genetic modifiers, so mutations in other genes that in combination makes some people have a worse outcome than others. There are questions that we are all interested in looking in different angles. So just to give you a sense that there is a lot of questions and we are trying to see if we can understand them better and correlate with then what you care the most, that is how I will do, what is the natural history, and what is the best treatment for me. This is for the LPAC. There was a paper from Europe in the JEP reports, and it really shows you how the first symptoms are earlier, how usually people have gallbladder disease, but with no other factors such as being obese. And the other important point is there is some case series showing that these patients might also be at risk of developing cholangiocarcinoma and hepatocellular carcinoma, so cancers in the biliary and the liver. And that's something, at least for adult doctors, that I think we have to start thinking and incorporating screening for these patients. So in the last few minutes before we open for discussion, I just want to say, as I think I'm bringing some answers, but a lot of questions too, we recognize this is an evolving field. So at my institution, I started something we call genome rounds. So it's really for certain things, certain mutations we know for sure. And I think that was very true with BSEP deficiency. It was previously discussed. But there are so many other variants and mutations that really need good genotype-phenotype correlation, really need the pathologists that read the biopsies, the liver doctors that see the patient, the clinical geneticist, and also we partner with pediatric hepatologists as well to really come together and discuss, is this something that we feel confident of making the diagnosis and how we'll best optimize the care. So we hold these genome rounds that is, some of you might know, like is very similar to tumor board rounds, where like if someone is diagnosed with cancer, then the pathologist, the radiologist will come together to discuss the best management. Here, the understanding is the same because of the complexity and also the open questions. So I think I'm very actually encouraged by the results from that. And so how I think I'll put this together with more simplicity, would say, in the past, as I told you, until 2010, 2011, we did single gene sequencing, and we looked for PFIC 1, 2, and 3. Then the cost of sequencing became much lower. The understanding of the genome became much better. So we are at the time where next generation sequencing is the norm, at least in tertiary academic centers. How I imagine the future, and I think we are being already discussing part of the future as patients, providers, and researchers, is how incorporate all this information to best diagnosis and to best care, and with industry too, of developing the right medication to the right subset of patients. So I'm really excited about what the future has to come. And this will have impact because we are already seeing that genomic analysis will improve diagnosis. The genome rounds, I think, will have more of that. And also centralized databases, and PFIC is actually an example with the registry to follow natural history. And also then for industry and for academia, also when we do clinical trials, really have a very good annotation. And not just on that gene, because as I mentioned, it could be actually a balance between certain genetic modifiers in combination with that gene. And that's why we all, or each of you with your family, have a slightly different experience. And then genetic medicines. So in summary, I think what I meant to say is that 10 years ago, I think if you say PFIC in adults, especially the pediatric hepatologist said, no way, this is a pediatric disease. I think with advances in genomic medicine, we are recognizing more of these genetic diseases in adults. I think it's important. I don't think there are many adult hepatologists here, but to think about it. If you don't think about it, you will never search for it and you will never find it. And that's why we are only finding them now. And then we need more data with registries, and I talked with Emily about that. And so hopefully we can do that for adults as well, of genotype, phenotype correlation of ABCB4 related disease. And I think with our current knowledge, what is safe is to say that we should do the best we can for a timely diagnosis, and then monitor really carefully. We do use orsodiol if someone has abnormal biochemistries, and we feel that if we see a biochemistry response, that means that is working. But we really need like long-term data to see if actually the patients do better and what is the real outcome. And with that, I would like to thank many people, both in the lab as well as in the clinic, again, like pathologists, clinical geneticists, also colleagues from other institutions, and most importantly, the patients and the families, and also the funding agents to do this work. And thanks for your attention, and I would love to have the discussion. Thank you.
Silvia, that was fantastic. Thank you very much for coming and sharing those ideas. I think what you've seen there is just the beginning of people applying genomics to adult disease. And as Silvia says, I think as pediatricians, we think of it very high up our agenda of diagnoses, but in most adult liver clinics, in case it's not obvious, they're overwhelmed by some very common diseases, which PBC, PSC, alcoholic liver disease, NASH, and it takes observant doctors to try and spot these slightly more unusual patients that actually don't fit the normal pattern, and that's what Silvia has been pioneering, and I think that's fantastic. And the other thing which I think she highlighted at the end, which probably is common to everyone, is the fact that the sequencing is actually cheap and easy now. It's interpreting the data is the complicated bit and putting it together and how it fits in with the clinical picture. And that's sometimes easier for the children because it's more clear what the association between the gene and the disease is. But from the adult diseases, making the connection between the gene and the disease is sometimes much more difficult. So thank you. Do we have any burning questions? Dr. Squires has his hand in the air, so we'll start over here.
Excellent talk. I guess one question that I have is how much as this is becoming more common knowledge in the adult from our adult colleagues is how much you're looking at maybe heterozygosity for these genes confounding some of the more common diseases you see like MASLD or fatty liver disease.
Yes, that's a really good question, it's hard to have a simple answer to that. So if you have two copies, then yes, with the MDR3 deficiency. With a heterozygosity for ABCB4 is really a challenge because I see that in patients with cholestatic disease, but I also see in patients with, for instance, fatty liver, because I sequence a lot of patients with unexplained liver disease that have cholestasis and not cholestasis. So is really a challenge to me. I really feel that the genotype-phenotype correlation is still very important. So if you see someone with high GGT, with abnormal AST and ALT, and really don't have any other confounding factor and has a rare damaging stop codon frame shift mutation on ABCB4, I have a hard time to not believe that that is contributing. What I'm looking very hard these days is, am I missing another variant in a non-coding part that our algorithms are not picking as well? So we know more, and now this is more like a little bit technicality, but there are silent mutations and intronic mutations that we thought they were not disease-causing, and now as we understand the genome better, we now know they are disease-causing. So that is where I think I can be missing, thinking that I only have a het mutation, but I might have something else that I'm not fully seeing. If they also drink alcohol or have other confoundings, I might say these might be contributing, but not be the full picture. Sorry for the long answer.
Hi. Okay. My name's Tara, and I really appreciate your talk. As a parent of two kiddos with ABCB4 mutations, FIC3, I it's really interesting to hear a discussion about this mutation, just because. So I've my oldest kiddo was in the red, right? That pediatric onset, cirrhosis, and now has been transplanted. But I have another kiddo who is in the blue, and I think so. It's been tough to navigate because the blue doesn't really exist in pediatric world. The only reason we know that he's a blue is because he had genetic testing done at birth because of older brother. So this is really interesting to kind of hear the way that you talk about this and disease progression with that, single genetic mutation versus having two. So what I wanted to ask is more of like a clarifying question, because we're sitting here as parents. When we hear PFIC as an adult, it's kind of a shift in thinking, because so far PFIC has been so prevalent in kids. And I just wanted to clarify, it seems like the BSEP deficiency and the FIC1 are, they present in pediatrics, and the MRD3 is sort of the wild card, that it can present in pediatric if it's red, but it can present later in life if it's blue. And I just wanted to clarify, because that's sort of what we were talking about over here, trying to understand. Is that how we're explaining?
Yeah, you sound like a researcher. I couldn't see it. I couldn't say it better. I think that's, as we are generating more of these data, it's kind of the knowledge that we are building. And I would agree with you that as I look at, we need to sequence more adults, because we know these diseases so much better in pediatric age than in adults. And I focus more on the ones that we are diagnosed in adulthood, but then you can even have the question of the ones that will grow and become adults and how they will do. But focusing on the first one, we are seeing a predominance of MDR3. I will not use PFIC3 in adults. So MDR3 deficiency, that could be more severe, or blue or red, and in adults, and very rare, or I have a few patients with BSEP deficiency. I never saw in my experience FIC1 in adults yet. Right. I don't know if that will happen. But that's kind of the trend, and we are trying to figure out how do they go from red to blue, because honestly, I think it's not gray. I don't know when you merge blue, it's yellow, like blue, and so there's a lot of patients that will go there.
Well, and so then as a follow-up question, we were chatting, because as parents who are not affected, we carry these mutations. So then we started talking of, well, does that mean that we're blue? So my thought was, well, no. And this was what we were kind of going through. So I'm going to use you guys because you're next to me. Their kiddo has a BSEP deficiency. So their genetic mutation is not the ABCAB4. But in my family, where it's the MRD3, I do have this. So that's the difference, where we were just kind of talking, like, does that mean that one day we might wake up and have, and I said, no, I don't think so. I think it's maybe me, but maybe not you. Is that right? And I'm sorry to kind of oversimplify.
No, you are so good that
we're just trying to figure this out.
I was talking with Richard Thompson last night, exactly like this, and you are giving in the first voice. I don't know if you want to say something or...
You go first.
Perfect. Okay, so I have to say, a couple of years ago, I thought that you as a parent I would feel more confident to say no risk, okay? As I'm doing more of these, and I see the nuance on patients, a little bit to the previous question, of how some adults have abnormal liver tests, and how that is, you are a little bit overweight, you drink a little bit too much, you are taking some medications. In adults, that all can cause for a certain abnormality of liver tests. And so they are very easily ruled out. But now I would be a little bit more careful. I would say we don't know yet. I think some mutations, your risk is exactly, I actually don't know if I have a heterozygous mutation in ABC before, but imagine I don't, will be exactly the same as me. But in other scenarios of other mutations or combination of mutations, you might be at slightly higher risk. So maybe you should follow check with your doctor every year. That would be my suggestion. And
So I'll tell you what I do in practice. If we make a diagnosis of BSEP deficiency, we generally test the parents genetically to prove that they're both heterozygous, and we don't do much else. MDR3 deficiency, we do the same thing, but I also check the liver biochemistry of the parents when we diagnose the children. And in a small number, they already have abnormal biochemistry. Serum gamma GT is the most sensitive, and I refer them on to my adult liver colleagues. And several of those patients are now on deoxycholic acid because they've got biochemical abnormality. As Silvia says, it may be they've got other risk factors for liver disease, and it may be only one thing that's contributing to the abnormal biochemistry. We haven't got proof that starting them on ursodeoxycholic acid is going to make a difference in 50 years' time to how healthy their liver is, but we feel it's the sensible thing to do. But I do think that it's much, much more complicated for MDR3 deficiency, as you've gathered. It's not just a simple yes-no, as it seems to be generally for BSEP or TJP2 and things like that. And if you're heterozygous, the risks are very low. You may be increased risk of cholestasis during pregnancy, for instance, but that's all. But I think for MDR3, you can have partial loss of function, and you don't have the early onset disease, but are at risk of a more slowly progressive disease, which very often would not present any clinical features to adulthood. And I do think we need to keep a very close eye on MDR3 deficient parents who are heterozygous, because they are not at zero risk, that's for sure.
I also would add, for females, so sorry, I'm like targeting you now, but if you didn't have intrahepatic cholestasis of pregnancy when you were pregnant with your children, I'm following that, but I also think that maybe, you are in a best category than the moms that actually develop that and then they clear, because it means that with some kind of extra stress in your body, you develop the disease.
Hi. So I have a ATP8B1 mutation, heterozygous, and I did have cholestasis of pregnancy, which my doctors totally ignored. They're like, oh, I don't know, the livers are wrong, but I'm sure it'll be fine once you give birth. And now, of course, it all kind of clicked in. But my sister actually has the same, carries the same gene, heterozygous, and she's had her gallbladder removed. And my question is, she's having trouble getting the doctors to understand that this is a thing. And so I'm curious about, so I've had to communicate to her. I'm like, no, this is totally a thing. Tell your doctors. But, because she's not part of the PFIC world, the doctors aren't believing her that, and it's a hepatologist in Mount Sinai in Toronto. And so it's really frustrating. So I'm just curious, as doctors, how do you want patients to communicate with you to get you to listen that it's a thing and do something about it?
In that, pediatricians are better than adult doctors. So what I presented here, maybe I gave the impression that the adult world embraced these, and this is how we do adult hepatology. It's how we do it at my institution with all the effort for many years. Some people are interested in the concept, and slowly, like Mayo Clinic, for instance, but really like tertiary centers, most of the care would be more of what your sister is going through. So, but it's not correct, as you can tell. So I would say, for specific things, I can make myself available. Like if they need more information, their doctors to understand, I will be happy to help. Of course, I cannot be their doctor, but I can at least educate the community. Because as Dr. Thompson was mentioning, in the adult world, there are so many confounding factors, being medications, alcohol, and being overweight, all contributing to abnormal liver tests. That's usually what the most adult doctors see. And of course, they tend to just, blame on that.
I think it's a big problem. It's a massive learning curve. And, actually, the problem in adults is so huge because the majority of adult liver disease is looked after by non-specialists. looked after by gastroenterologists in clinic, and there's a lot of untouched disease because they just haven't got the message yet.
But
Emily-
in a positive note, though, and there is a future ASLD present here, I think we are working with ASLD and the adult doctors to, I think we will do better in 5 years. You know, I think we need a lot of education like in any other
So
realm.
Emily wanted to point out that she should go with the printout of the paperwork to the clinic. Oh, and her papers, sorry, yeah. But if she goes with a gene mutation, go take the papers, print them off the internet, go there fully armed. I've got a question over here. Saul, do you want a quick chip in?
Silvia, this is great. I have a very specific advice question that I need from you, okay? And it has nothing, and it's a short answer.
I'll try.
All of us as pediatricians want to help everybody in the room when we're taking care of the families, right? And so we say, your kid has this, and every parent says the same thing. Hey, wait a second, do I need to worry, right? Not just my other kids, but do I need to? And then we say, well, sure. And there's this air gap between peds and adult medicine that's just normal, but wrong, okay? So the way that I want to hear from you is, most of the people we want to refer, perhaps, the parents for an evaluation, what we need is a very short list of things that you would like us to tell the adult hepatologists to pay attention to. So, do they need bile acid scent, which is not normal? Do they need a GGT, which is not normal? Do they need something else? So that we can be, as a doctor to doctor, and not just give the parents something to say, tell this to whoever you're going to see. What can we do when we make that referral to someone, and not in the ivory tower, in real world, everywhere that someone says, oh God, what the hell is this, on the other end of the line?
Yes, so I think, you know, to try to really be straight to your question, 2 things from history. Do you still have your gallbladder, and was it removed early on? I think if you say to any adult hepatologist that the gallbladder was removed before the age of 30, we think is abnormal. And also for the moms, so that's more gender bias, but if they had intrahepatic cholestasis of pregnancy and they had the gallbladder removed, most of adult hepatologists think this is not normal. In terms of labs, nothing fancy. I would just say AST, ALT, and GGT. So that is, yeah.
So we've got one more question, but Henk-Jans just pointed out that we have now in the European Association produced a clinical practice guidelines which addresses some of these issues, which will be out in the next couple of months. So there will be some guidance based on the evidence that's available, which we can, you know, show to people, say, look, this is what we think you should be doing. I think we've got one more last question.
Yes. I have a question. If there's been advancing for the testing, if your tests are more than 7 years old, is it beneficial to have it redone? And I did have a device for you, the lady with the blue shirt on. Do print off your paperwork, because I had ICP with all 3 of my pregnancies. The first one was undiagnosed. I did print off literature, and I was his first patient, and he argued with me, and I said, just test me. I said, prove me wrong. He was like, oh my gosh. So
I think your main question was, do you need retesting genetically? I mean, if you haven't had a diagnosis made. Oh.
No, if you have had a diagnosis already made, is it, because she's talking about there's more specifics that may be helpful. So is it better to have?
So Sylvia,
I can address, yeah.
Go on.
So if you have BSEP deficiency with 2 mutations and it's done, that will never change in your life. You can repeat. If you have 1, that is where, depending on what test you had done, repeating the same test, no, but we can talk offline, actually. There is something more fancy that you can consider.
But I think the important point there is that the genetics has not changed. The result, but the interpretation may have changed in the last 7 years. So
Correct.
I think you do need to go back and say, actually, does our understanding change? Do we need to act differently now? Because that definitely has changed in the last 7 years. Yeah.
Yes.
Sylvia, thank you very
Thank
much
you.
indeed. That was fantastic. And I hope you got everyone some insight into what's really the complexity of what's happening in the adult world and some of the pioneering work that's happening. So that's the end of this first session.